Hi, good afternoon, everybody. Thank you so much for joining us for today's Leaders Initiative Talk. My name is Stephanie, and I'll be helping monitor things here on the back end. Just a couple updates. Our next Leaders Initiative seminar will be August 18th, and Dr. Natasha Nemers will be presenting Beyond Traditional Family Support, Caring for Older Adults Living Alone with Cognitive Impairment. And so make sure everybody gets that on their calendars in the next few days. I will also be sending out a Qualtrics evaluation and a follow-up email afterwards. So please take the time to fill that out so we know of other topics and yeah, different things you'd like to hear in future Leaders Initiative seminars. So with that, I will pass things over to Courtney for our introductions.
Great. Thanks so much, Stephanie, and thanks everyone so much for joining us today. We're excited to welcome Dr. Emile Pinarbasi as our speaker for this month. Dr. Pinarbasi completed a pathology residency and neuropathology fellowship at the University of Michigan, and she's currently a postdoctoral fellow in Dr. Sami Barmada's lab. Her research focuses on limbic predominant age-related TDP-43 encephalopathy, a highly prevalent but understudied neurodegenerative disease. And with that, I'll turn it over to Dr. Pinarbasi.
All right, thank you so much, Courtney. So thank you so much for inviting me to speak today. As Courtney mentioned, I'm Emily. I'm a clinical instructor in neuropathology, currently doing my postdoctoral fellowship in Sami Barmada's lab. And today what I'd like to talk to you all about is this set of neurodegenerative diseases that are characterized by the mislocalization and aggregation of this RNA binding protein called TDP-43. And I'm particularly going to focus on kind of the redheaded stepchild of TDP-43 proteinopathies, which is this disease called late. And I just want to give a little spiel that I'd like this to be kind of informal, so please feel free to unmute and ask questions if you have any, or throw them in the chat. Yeah, please don't be shy to interrupt. All right, so first I'd like to kind of back up a little and give some context. So as we all know, neurodegenerative diseases are characterized by the accumulation of misfolded proteins. And we also all know that some of these proteins are repeat offenders, right? So we know that misfolded tau accumulates in this whole host of neurodegenerative diseases. And over here on the left, I just have two examples listed: Alzheimer's disease and Pick's disease. But we also know that even though they both have tau, these diseases are pretty different, right? So the tau aggregates look different. In Alzheimer's disease, they form these kind of flame-shaped aggregates called neurofibrillary tangles. In Pick's, they form these round inclusions known as Pick bodies. They also tend to affect different areas of the brain. So in Alzheimer's disease, we know that the tau pathology begins in the locus coeruleus, progresses to involve these limbic regions, and then finally the cortex. In contrast, in Pick's, the earliest and heaviest affected areas tend to be the frontal and temporal cortex and hippocampus, with later involvement of structures like the brainstem and the cerebellum. So this is kind of confusing, right? How can the accumulation of this same misfolded protein lead to such disparate diseases? Well, with advances in structural biology, and in particular the advent of single particle cryo-electron microscopy, or cryo-EM, we've begun to realize that the tau that's present in these two diseases is not actually the same. So if you actually take a look at the structure of tau within the filaments that you see in neurofibrillary tangles, you see that it forms this protofilament that to me kind of looks like a candy cane. In contrast, if you look at the tau filaments in Pick bodies, what you can see is that the structure is completely different, right? To me, it kind of looks like a wonky stick. All right, so I'll just mention that in the structural field of tauopathies, this field is actually pretty well developed. So we actually know the structures for a lot of these diseases. And sorry, I'll also mention that this finding that there are kind of unique tau structures in these unique diseases has really led to this working hypothesis in the field that everything that we see about these diseases, the morphology of the aggregates, the predilection for certain regions of the brain, we really believe that this is all secondary to this unique conformation. So this is the working hypothesis. And therefore, if we want to answer important biologic questions about any of these diseases, like, why are some regions of the brain uniquely susceptible? Why are some resilient? In order to answer those questions, a really critical first step is we have to define the structure, right? So this has already been pretty well done in the tauopathies, but where we have some gaps are when it comes to these diseases that are characterized by the misfolding of our favorite protein in the Marmota lab, which is TDP-43. And so this project was really a collaboration between myself, Sammy Marmota, who's a neurologist who studies TDP-43 pathology, and then Shamal Musliganti, who's a structural biologist. And this was really an effort to try and kind of fill in some of these gaps. All right, so I want to talk to you a little bit more about these different TDP-43 proteinopathies. So I'm going to do a little compare and contrast here. On the left, I'm going to talk about really the prototypical TDP-43 proteinopathy, which is frontotemporal lobar degeneration, or FTLD. And then on the right, I'm going to talk about this TDP-43 proteinopathy that no one ever talks about, limbic predominant age-related TDP-43 encephalopathy, or late. All right, so I'm kind of starting off here by showing you some immunohistochemistry that just show you what these aggregates look like. And you'll see that unlike what I showed with the tauopathies, there's not really like this distinct aggregate morphology here. They kind of look similar. So how are these diseases different? The answer is really the distribution. So in FTLD TDP, you have this really broad distribution of TDP-43 pathology, basically throughout the entire brain, including the spinal cord. This is really on a spectrum with ALS. In contrast, in late, TDP-43 pathology is really confined to these medial limbic structures, and that's true even in very advanced disease. All right, so you can imagine that if the TDP-43 pathology is in really different places, that's probably going to have some effect on the clinical presentations. And, that's what we see. So in FTLD, these patients have multi-domain cognitive impairment, often personality changes, frequently motor symptoms when there's involvement of the spinal cord. In contrast, in late, this really often is seen more as an isolated amnestic syndrome, and it's often quite indolent. And then finally, the epidemiology is also quite different. So FTLD TDP is pretty rare. The incidence is, about 1 in 100,000. And the age bracket here is kind of this age that's sort of straddling like middle age and elderly. In contrast, late is seen in much older patients, so usually over 80, and it's really like highly, highly prevalent. So studies of community-based autopsy cohorts suggest that this is seen in around 30% of patients over 85. So you can imagine this is kind of poised to become like really a public health crisis when you think about like the burden on our healthcare system as the population ages. And then I'll also mention that the comorbid pathologies are also pretty distinct. So if you look in the brain of a patient with FTLD TDP, you'll see that this is really kind of the main event. There's not a lot else going on. In contrast, when you look at the brain of a patient with late, usually there is something else going on. Late tends to be a more secondary pathology, and usually the primary pathology is high-stage Alzheimer's disease. All right, and so this brings me to the thing that really unifies these diseases, as well as, unfortunately, pretty much every neurodegenerative disease, which is that we don't have any disease-modifying therapies. And, I really think that one of the things that we can attribute this to is that we just don't understand very well at all how these diseases progress. And I'm going to bring it back to the structure and say, I think a key critical question that we should be trying to address first is let's kind of define these diseases in order to answer some of these important biologic questions, and hopefully, of course, end up in something that can help these patients. All right, so the kind of question we're starting with is, are there structural features of TDP-43 that can underlie the limited disease distribution that we see in late? And now I'll kind of give you like this other side of the coin. So I've really only been talking about the TDP-43 pathology, and I've sort of yammered on about how it's so limited and so indolent. But the other side of the coin with late is that there's also tau pathology, right? I mentioned that at the beginning. And actually the tau pathology in late is more advanced. And what I mean by that is that if you take a set of Alzheimer's disease patients and you divide them into those with and those without late, the patients with late tend to have more advanced tau pathology with a higher Braak stage and a more severe clinical decline. All right, so this question has kind of evolved into, are there unique structural characteristics? So I'm just going to try and move these meeting controls really quick. Okay, maybe I won't. All right. All right. So it's kind of evolved into, are there unique structural characteristics of either tau or TDP-43 that can explain what we're seeing clinically? All right, so what was the approach? So basically, so I'm a neuropathologist. I look at these cases like, as a part of my day job. So basically, I took a look at all the late cases that we had in our brain bank, screening them for ones that had dense TDP-43 pathology so that we could do some of these structural characterizations. So what does this involve? Basically, we obtain frozen amygdala from the Michigan Brain Bank. This is a brain region that has, the densest TDP-43 pathology. We use this technique called sarcosyl fractionation to try and enrich these aggregates. So basically, this involves solubilizing the tissue in this detergent, where basically all natively folded proteins will be soluble, but all the aggregates will be insoluble. And so then you can spin at a really high speed and pellet these. All right, next, we want to do some techniques, Western blotting and negative staining, to confirm that we've actually enriched for these aggregates. And then finally, we want to use cryo-EM to get a high resolution structure. Okay, so the first case I selected was this patient that came to autopsy at age 94, had high Alzheimer's disease, and also high stage late with really dense TDP-43 pathology. So that's why I picked this case, right? The clinical history was actually a little bit interesting, kind of maybe not exactly what you'd expect given this neuropathology. So this patient first presented to the neurology clinic at 82 years old with what he called like leaning attacks. So basically he would have these transient episodes where he wouldn't be able to sit or stand straight. And due to basically the description of these episodes, as well as some imaging findings, these were interpreted as transient ischemic attacks. Over time, these became more frequent. And then a couple years later, he now began to experience this multi-domain cognitive impairment with difficulty, finding familiar places, difficulty remembering different words, and some, troubles with executive function. So couldn't remember to take his medications. And this kind of continued on a steady decline until he died at age 94. And the clinical diagnosis here was this mixed cognitive and movement disorder. All right. So what did the neuropathology look like? So this is this patient's amygdala. So, I already mentioned he had high Alzheimer's disease. So, it's not surprising that there were quite a few plaques, diffuse and neuritic. There was tons of tau pathology, so lots of these neurofibrillary tangles, neuropil threads. And then, of course, I selected this case because there was a lot of TDP-43 pathology, right? And you can see there's a lot. It's pretty dense. All right. So the next step was to perform this sarcosyl fractionation. So you have your kind of input, which is total, and then your supernatant, which should have like all the soluble stuff, and then the pellet should be all your insoluble aggregates. So the next step was to see whether this fractionation had kind of worked as we'd hoped. So we did some immunoblotting for A beta. You can see really nicely this huge high molecular weight band suggesting all these like big A beta filaments are in fact in the insoluble fraction. So that's good. Pretty similar thing with tau, phospho-TDP. There is something similar in that we see enrichment of these high molecular weight bands, but you'll notice that this band is a lot wimpier than the other two, which is going to cause us some trouble downstream, unfortunately. But I think this is kind of just par for the course with late. We know the TDP-43 pathology, unfortunately, in these cases, is just not the major pathology. So it's always going to be challenging to get enough material. And then finally, we also immunoblotted for TMEM106B. So for those of you who aren't familiar, this is a lysosomal transmembrane protein that is known to form amyloid fibrils across a whole host of neurodegenerative diseases and also in normal aging. So we expected it in this case, and then we saw a ton of it, and also it's in the insoluble fraction. So that's all good. All right, so what's the next step? The next step is to take this pellet, put it on grids, and now we can add this heavy metal stain, urinatyl formate, that will basically provide contrast so that we can see some nice details of these fibrils and kind of just see what's there. And what we got is a lot of fibrils, so that's really good. And you can also, I think, appreciate that this is a mixed population of fibrils. So you have guys like this that have this sort of spiral morphology. This is a really good look for the paired helical filament of tau that you see in Alzheimer's disease. You also see things like this. So this kind of double barrel filament is classic morphology that you see with the TMEM106B doublet. You also see things like this, long skinny guys that we were really hoping were going to be TDP-43. But of course, we don't know based on morphology alone. So one technique we can use is something called immunogold. So you take the same material, you incubate it with the primary antibody of your choice, and then gold beads, they're coated with a secondary antibody. And basically, if your filaments are immunoreactive for whatever you incubated with, then they're going to end up coated with these gold beads, which you can then see under EM. And so you can see that these long, skinny filaments are in fact immunoreactive for phospho-TDP. So we were super excited about this. And we can also see some reassuring things like these things that look like paired helical filaments are in fact immunoreactive for tau, and these things that look like TMEM106B doublets are immunoreactive for TMEM106B. So all really, really good signs. All right, so what's the next step? So first I'm just going to pause and, oh,
One
sorry, was there a question? Yeah.
Yes. Did you did co-labeling in the immunogold to see
No, we
you
didn't.
have
We thought about it. We thought about it like using different sizes of gold beads.
immunogold? Mm-hmm.
Yeah. Yeah.
Okay, good.
All right. So sorry. So I wanted to pause really quickly and just mention that this next part is really all like spearheaded by this extremely hardworking and talented graduate student in Shamal's lab, Jamin Rana. So I just want to give a shout out here. Okay, so what's the next step? The next step is to take this same material, apply it to grids, and then on these grids, you basically have like hundreds and thousands of areas where you can image. So the next step is to survey those areas and find areas that are the best for acquiring images. And what we're looking for is areas like this, where the ice isn't too thick, it's not too thin, and you have a good density of fibrils. Okay, once you have areas like this, you go ahead and automatically acquire hundreds of thousands of images. And then what Jamin did was manually annotate each of these images, basically selecting areas where you have fibrils that aren't obscured either by crossing fibrils or by kind of like random gunk that's in your sample. All right, so once you have these hundreds of thousands, sometimes even millions images, low resolution images, what do you do next? Well, next you can actually feed these into an algorithm. What the algorithm will do is separate them into different classes. Each class should represent a different view of your filament. Then, because you have basically like hundreds of thousands of low resolution images, what you can do is basically use this to average out the noise and end up with a higher resolution image of your filament. And so we call these class averages. So this is the class average that Jamin got for the tau straight filament. And now one other point is that because you flash freeze these, when you have these particles that are randomly tumbling in solution, you get them in a lot of different orientations. So you get a bunch of different views of the same filament. And you can use this to your advantage to try and build a three-dimensional model, which is, of course, what Jamin did. And so here's the three-dimensional model of the straight filament of tau. And when you have something like this, you can do some really clever things like slice through it and look at the actual structure of the protofilaments. And hopefully this looks familiar from an earlier slide. You can see these same kind of candy cane shaped tau protofilaments that I told you are like the classic shape for Alzheimer's disease. All right, and so what Jamin did was overlay his model on top of the published structure for the tau straight filament. You can see it's a perfect fit. All right, so this is good, right? We saw what we expect in Alzheimer's disease in our patient, and in fact, it matches perfectly with the published structure. But of course, Jamin didn't stop there. He went on to do several theses worth more of work. So we got class averages for A beta, TM106B, the singlet and the doublet. He tried really, really hard to get a class average for TDP-43, but unfortunately, there were only around 5,000 particles in the sample, and you really need a minimum of 50,000 to get a structure. So that was unfortunate. But of course, he didn't lose heart. He made this three-dimensional reconstruction of the straight filament of tau, like I already showed you. He also got a class average for the paired helical filament, which is these same protofilaments, but like in a different relative orientation. And then finally, he actually saw this third tau filament. And this matched perfectly with the published structure of a filament that's been described in chronic traumatic encephalopathy, or CTE. And you can see, unlike the candy cane, it's got this kind of cavity in there, so it like sort of looks more like a hockey stick. Okay, So chronic traumatic encephalopathy, it's a mouthful, but what is it? So this was first described by this neurologist, Dr. Martel, back in the 1920s, as this phenomenon where these boxers, decades later, developed this cognitive impairment and these behavioral symptoms. And then in the 1970s, the neuropathology was first described in this case series as these pathognomonic lesions where you have this kind of irregular tau staining at the depth of a cortical sulcus, sorry. And now, of course, we've begun to recognize that this doesn't actually just occur in people who box. It occurs in a whole variety of contact sports, including, hockey and football, as popularized by Will Smith. All right, so we have CTE fold tau. Do we have any neuropathologic evidence of CTE in this patient? So over on the left, I'm just kind of reproducing those images of the pathognomonic CTE lesion. And then here is a tau immunostain in our patient. So here you can see some neurofibrillary tangles and neuropil threads in these deeper cortical layers, kind of consistent with what we always see in AD. But then over here at the depth of the sulcus, sure enough, here's this irregular tau staining. If we look a little bit closer, we can see we've got tau in neurons and in astrocytes kind of loosely grouped around a vessel. All right, so this is CTE, the first ever diagnosis by cryo-EM. So that's kind of cool. All right, so was there any history of repetitive head impacts in this patient? Not really. No known history of contact sports. This patient did have like a car crash back in the 80s. And I know he broke his leg, but I don't know anything else about that. So I don't know, maybe there was a concussion. We just don't know. Definitely no strong history of repetitive hand impacts. But I'll just remind you that the original purpose of this was like we wanted to find the structure of TDP-43 in late, right? And this actually introduces a complication, which is that TDP-43 pathology is also seen in the context of CTE. So now we don't know whether this TDP-43 pathology is late or is it a component of the CTE. All right, so this was weird and challenging. So I showed it to a bunch of neuropathologists here and also some neuropathologists at other institutions. And we all agreed like CTE is present. The CTE is favored to be low stage, although it's really challenging because the staging in the context of other tau pathologies, like the staging algorithm just kind of doesn't work. And we all favored that this TDP-43 pathology was late, but we really couldn't be sure. All right, so to summarize, we have CTE type tau. Weird, surprising. We have TDP-43. We don't know whether it's late or CTE, but honestly, the whole thing is kind of moot because we didn't actually have enough fibrils to get a structure anyway. So we definitely need to look at another case. All right, so here's case 2. So this patient came to autopsy at age 86, intermediate stage Alzheimer's disease, high stage late with some dense TDP-43 pathology. Of course, that's why I picked it. Again, kind of an interesting clinical history here. So this patient first presented at age 74 with this history of having all these falls, even though he was on level ground, losing balance, difficulty climbing stairs. Over the next couple of years, his motor symptoms worsened, and he began to start to have cognitive symptoms like forgetting names, faces. Around this time, he had a MoCA that showed, some cognitive impairment. And then he began to develop like really prominent Parkinsonian symptoms, which were partially responsive to levodopa. And basically his motor symptoms really continued to progress until he died. And his clinical diagnosis that he got was corticobasal degeneration. So, there are a subset of patients that present with corticobasal syndrome and are found to have Alzheimer's disease type pathology at autopsy. It is kind of unusual. All right, so what do we see in this patient's amygdala? So this patient, their Alzheimer's disease was a little bit less advanced. So you can see there's definitely less beta amyloid pathology. There's also, there's definitely tau here, but there's a lot less. But of course, this was my second round pick because there's also quite a bit less TDP-43 pathology, although you can see it's there in these higher power images. All right, so now we're going to do the same thing, right? We're going to try and get this sarcosylin soluble fragment or fraction. We're going to do some negative staining to see what we see. And again, we see fibrils. These fibrils are a lot less dense than what I showed earlier, but you do see things that look like, again, the paired helical filament of Alzheimer's, and you see these long skinny guys. Okay, and so now for this case, we were really, really laser focused on trying to get a structure for TDP-43. So when Jamin went through, he basically only annotated these thin fibrils that he thought might be TDP-43. All right, and then we were kind of disappointed in that we only got 10,000 particles. So again, not quite enough for a structure. Of course, Jamin did not give up. He's still working very industriously at this. We basically did an additional purification, made more grids, and we're just trying to like brute force this, get enough particles to get a structure. But the thing that Jamin did see is again, this same CTE fold tau. So there were about 88,000 particles of this CTE fold tau, enough to actually build out a model. And so here again, we have our model in blue overlaid on the published structure in black. And you can see again, it's a perfect fit. All right, so what about this case? Is there neuropathologic evidence of CTE here? Okay, the answer is kind of no. So in all of these cases, we take 5 standard cortical sections to begin with. All of these, there's basically like really minimal tau pathology, like scattered neurofibrillary tangles or the cores of neuritic plaques, nothing that looks like a CTE lesion. Okay, well, that's fine because I know this pathology can be focal. So I took a bunch of additional sections. So I took 10 additional sections. Most of them had multiple pieces. So it was 16 pieces of cortex, focusing on these regions that I knew are preferentially affected in CTE. Again, not even a single whisper of a pathognomonic lesion. All right. Okay, fine. Let's take more sections. Okay, so 10 more sections, now 18 additional pieces of cortex. And again, really nothing that looks like a CTE lesion. So this is at this point around 30 sections. Now I'll mention that these sections are about 2 millimeters thick. So you can imagine like we're not really sampling a significant fraction of the brain, right? And in fact, only half of this brain is actually fixed in formalin. The other half is frozen. So is it possible that there's neuropathologic CTE that is unsampled? Yes, I think it's possible and probably and likely really given what we see on cryo-EM. But no neuropathologic evidence that we see so far. All right, well, what about a history that's, consistent with this? Again, not really. So no known history of contact sports, no known history of head trauma, although remember this patient did first present with falls about 10 years before he died. So maybe, there were a lot of sort of subclinical head trauma at that point. All right, so what does this all mean? So I'll just mention as like for a little bit of context that when you look at patient populations like this, so in these kind of large neurodegenerative brain banks, you actually see a really, really low incidence of CTE, so around 1%. And when you look at these patients, they pretty much all have a history of contact sports. So it's pretty hard to believe that this is kind of just occurring by chance. And what I've shown you here is I had 2 cases of Alzheimer's disease plus late with no neuropathologic diagnosis of CTE, no clinical suspicion of CTE, and no clinical history of repetitive head impact. Both of them have this CTE fold tau, and one showed definitive neuropathologic CTE. All right, so what do we know about this CTE fold tau? Well, of course, I've already told you all about CTE. So you get these kind of superficial cortical neurofibrillary tangles. And of course, you've got the hockey stick protofilament. But what I didn't mention is that this is actually also described in some other neurodegenerative diseases. So one of these is subacute sclerosing panencephalitis, or SSPE. This is a fatal inflammatory disorder that's induced by the measles virus. You basically get it like after a couple years of being symptom-free. And in these patients, you get these superficial cortical neurofibrillary tangles, and the structure of the structure of tau here is again this hockey stick. Okay. And then there's this third disease, this ALS Parkinson's disease complex of Guam. So this is an extremely rare neurodegenerative disease. It's only seen in one area of the world, Guam, and then this key peninsula of Japan. Clinically, these patients have Parkinsonism and ALS, and if you look at their neuropathology, they have these, again, superficial cortical neurofibrillary tangles, and of course, I'm mentioning it because they have this, hockey stick tau. All right, so what do these all have in common? Well, these actually all have a prominent component of TDP-43 pathology. So what I've told you so far is CTE fold tau has so far been reported in 3 neurologic diseases that all have TDP-43 pathology, and now I'm reporting it in 2 cases of Alzheimer's disease with TDP-43 pathology. All right, so I think this leads to a very natural question of like, is this a general association between this conformation of tau and TDP-43? And if there is a general association, then it leads to kind of an obvious next question, which is, is there an underlying causal relationship? So at this point, we're basically going to leave behind my data and enter in the realm of speculation and future plans. All right. Okay, so how am I planning to try and look at this? All right. So first, we want to continue using the same single particle cryo-EM technique. So of course, we've only looked in 2 cases of late so far, but I actually have some frozen tissue for 4 additional cases. For an obvious kind of next step is to look in here and see if we see the same CTE fold tau. We're also going to look in a couple other neurodegenerative diseases where you have this co-occurrence of tau and TDP-43 pathology. So one of these is corticobasal degeneration, or CBD. Now, I'll mention that this is a primary tauopathy that has already been structurally characterized. But about half of these cases also have kind of widespread TDP-43 pathology. And the cases that were structurally characterized were actually cases of pure CBD. So I think it would be really interesting to use the same technique and see, when you also have TDP-43 pathology, do you now have some minor component of the CTE fold tau? All right, and then I also want to look in this kind of recently described phenomenon called temporal predominant neuroastroglial tauopathy, which is basically this kind of wimpy tau pathology that you get in patients that have FTLD TDP and also have a polymorphism in TMEM106B. So it would be super cool to find out whether this tau has the same CTE type fold. All right, but of course there's, a problem with single particle cryo-EM, which is that this is extremely low throughput, right? It'll take us kind of a minimum of like probably 4 or 5 months to do this. And, it's only a handful of cases. Really, we need a higher throughput method. Ideally, something like an antibody. The problem here is that CTE actually has the same tau isoforms as Alzheimer's disease. So an even mix of 3R and 4R. So you can't use, those isoform-specific antibodies. And while there are a whole host of conformation-specific tau antibodies, there aren't any that are specifically detect CTE. However, there is a published antibody that is at least reported to be specific for AD, and that's this MC1 antibody. So what I'm showing over here on the left is an image from this publication where they stained an Alzheimer's disease case and then some CTE cases with these phospho-specific tau antibodies, and then this MC1 conformation-specific antibody. And what you can see is that the phospho-tau is picking up all of this, all these neurofibrillary tangles in CTE, but the MC1 antibody is completely negative. And then that's quantified over here on the right. And so we have this antibody in hand. So the idea here is like, first, let's validate it. And next, let's stain a whole bunch of amygdalas of patients with Alzheimer's disease, pure Alzheimer's disease, and then those with Alzheimer's disease plus late. And then the idea here is that if a lot of these patients with late actually have a component of CTE type tau, then we should see a lot of tau that's basically AT8 positive, but MC1 negative. All right, so that's one plan. Okay, and then I'm also really, really interested to try and figure out, is there some underlying causal relationship? And you can imagine that a causal relationship could go multiple ways, right? You could have this CTE fold tau promoting TDP pathology. You could have TDP pathology promoting CTE fold tau. You could have some underlying cause promoting both of them. But we actually have some tools in hand in our lab that could try and address at least one of these. And that's a question of whether CTE fold tau can promote TDP-43 pathology. So what we have in hand are what are called these TDP biosensor cells. So these are basically immortalized human kidney cells that are expressing the C-terminal fragments of TDP-43 that are fluorescently tagged. And when you add TDP-43 fibrils, which you can either make recombinantly or you can isolate from patient brains, then you end up getting aggregates in these cells. And then you can quantify like the number of aggregates you get per cell. And here's just an example in my own hands where I, added some control brain lysate, and there's basically diffuse fluorescence. But when I add the sarcosylin soluble fraction from a patient with FTLD TDP, you now have all of these aggregates. All right, and so it's a pretty, simple experimental paradigm. Let's just add some CTE type tau and see if we get more aggregates. So that's work that's ongoing. All right, so just to summarize, what we were looking for was the TDP-43 structure in late. What we found was, surprisingly, the CTE fold tau in 2 separate cases of Alzheimer's disease plus late. I talked to you about how there's some suggestion in the published literature that there may be an association between CTE fold tau and TDP-43, and some future directions include using conformational antibodies and single particle cryo-EM to try and explore the strength of this association, and trying to use some of these TDP biosensor cell lines to look for causal association. And then I also just wanted to briefly mention that this is sort of part of a larger effort to try and really dig down and understand, like, why is the disease distribution in late so limited when you compare to FTLD TDP? So I've really only talked about one of these aims, which is the structural aim, or really a sub-aim of aim 1, which is the structural aim. But I'm also interested in exploring post-translational modifications, kind of the intrinsic ability to propagate. I'm also really interested in whether, if you look at these limbic structures that are affected both in late and in FTLD TDP, is it actually the same cells that are accumulating TDP-43 pathology? And do they have conserved downstream transcriptomic changes? And then I'm also really interested in like whether there are kind of unique events that are inciting TDP-43 misfolding in these 2 different contexts. All right. With that, I just want to thank everyone who made this work possible. So of course, my mentor, Sami Barmada, of course, Shamal Mosaliganti, and the 2 graduate students who really like spearheaded this work, Shaman Rana and Martin Fernandez, everyone else in the Marmada lab, my advisory committee, Andy, Jack, Mark, Roger, who's like an honorary member of my advisory committee, and then of course my funding. So the R25 Clinical Neuroscientist Training Award, as well as the MADC REC. And now I'm happy to take any questions.
Excellent, Emily. When you look at the CTE, you look at the diagnosis of using tau and looking at the depth of the soul sites. Did you see TDP-43 in those depth of the soul site too, or not?
No. In some cases, it has been reported. So that's one of the reasons why we thought the TDP-43 pathology in that first case is actually more likely to be late than associated with the CTE, because it was limbic and there wasn't much in the cortex that was associated with these regions.
I see. To enrich TDP-43 from the sarcosylin soluble fraction, have you tried to
immunoprecipitate?
Yeah.
No, we haven't tried it yet. Basically just because we're not really sure it'll work, and this tissue is so precious.
It
is kind of an obvious thing to try.
Yeah, we have been able. I work for with tau, so and we very effectively and specifically immunoprecipitate tau from the sarcosylin soluble fraction from the pellet. So it's something that it work at least for tau, but I understand with the limited resource of the tissue is
Yeah. I mean, I think it's definitely worth trying. It's, I think, kind of a natural, if we can't sort of brute force it on that one case, I think it's what we're going to have to do.
One more question, in terms of the space, which is, the spatial distribution of TDP-43 pathology and tau, for example. I mean, I don't have any reason to think that their CTE fall in other regions, you know, it's not exclusively to the depth of the soul size, but or around blood vessels as well. But it could be in other regions. But do you think that that's go back to my question of the co-labeling with the monogoal? Do you think that they, you know, can come together in one structure, or they are, or they can be in the same cell together aggregate, or they're in different cells aggregated? What do you think about that?
It's a good question. So heteromers have been described in like a subset of FTLD TDP, like the annexin A11 forms a heteromer with the TDP. We haven't seen anything that looks like a TDP tau heteromer. So at least in terms of like structurally, we don't see that. People have reported that tau and TDP-43 can interact, and I think it's certainly a very attractive hypothesis. That, you know, that could be what's going on with this CTE fold tau and TDP-43. In terms of like, when you have both of these pathologies together, are they in the same cell? And the answer is sometimes. So basically, if you look at all the cases that have all the cells that have TDP-43 pathology in like a case of late, about 20% of those cells will also have a nerve fibrillary tangle. And what's the next point? Oh yeah, the next point I wanted to make is that when you look at the distribution of tau pathology in a case of Alzheimer's disease versus a case of Alzheimer's disease with late, the distribution is slightly different. And you tend to see more tau pathology in these areas that have TDP-43 pathology. So for example, in the hippocampus, you tend to get a lot of TDP-43 pathology in the dentate gyrus. And you see more tau pathology in the dentate gyrus, Brock stage for Brock stage, in cases that have late. So there is some suggestion that these pathologies are working together. At least a hint.
Yes, I love it. No response. You think of like, but
All right, I think unless there are other questions, I think we can just end early.
Yeah, I think absolutely. Thank you very much for joining us today. If we don't have any other questions, we'll just end a few minutes early. Thank you so much, Emily, for that great presentation. And yep, I will send out a follow-up email with the evaluation later on today. So we'll see y'all later.
Thank you, Emily.
All right, thank you.
Yeah.
Bye-bye.